Good evening, doctors. My name is Ankur Gautam, and on the behalf of FDC and MedTalks, I welcome you all to yet another episode of 52 Weeks of Diabetes Essentials with Dr. Sanjay Kalra, Season 3. Doctors, as we are taking up many of the topics, today's topic is very interesting topic: reducing renal risk in diabetes. Now, today's session is brought to you by your zero calorie hydration partner in Result Zero. Now, before moving forward, I would like to announce last week quiz winners: Dr. Surjit Kalsi from Noida, Dr. Anand Purande from Mumbai, Dr. Vinay Desai from Thane, Dr. Ashwani Kumar from Kanpur, Dr. Satish Kumar Jain from Bangalore, Dr. Ashutosh Das from Tamluk, Dr. Shantanu Kumar Bhattacharya from Kolkata, Dr. Sumita Sharma from New Delhi. Thank you, doctors, for taking part in the quiz. Now to enlighten us regarding today's topic, I would like to welcome our host, Dr. Sanjay Kalra, President, South Asian Federation of Endocrine Society. Over to you, sir.
Thank you, Ankur, and good evening, everybody. Today is a special day for us at Diabetes Essentials because we have an expert physician speaking to us about the topic. And the topic is reducing renal risk in diabetes. Now, the kidneys, they are two small organs, very important organs. We have the left one and the right one. Our patients make it a point to ask us, how are my kidneys doing? And then when I say they are fine, then the question is both of them, both the left and right. They want that answer. Now, in ancient times, the kidneys were considered the seat of the soul, soul, soul. In the Bible, in Jewish literature, in Egyptian literature, ancient Egyptian literature, it is thought that the kidneys were the place where you decide what is good, what is wrong. One reason for this may be that when animals were being sacrificed, a sheep, for example, when you dissect the sheep after having sacrificed it, you look at the innards, the inner organs, and the kidneys are the last ones to come out. So the people at that time might have thought that the kidneys are, such a deep organ, deep-seated organ, that they contain the deep secrets of the body, which is how your mind thinks. That was long ago, the importance of the kidney. In fact, when you look at the Bible, in the Bible, the word kidney, they use the word reins, R-E-I-N-S, is used again and again to talk about the importance of the kidney. And it is said that on Judgment Day, God will judge us by the state of our kidneys. I would like to humbly submit, however, that on Judgment Day, God will judge us physicians, by the state of our patients' kidneys. That is how we will be judged. But did we do a good job or not? When you read the hadiths are sayings of Prophet Muhammad. Then also you find that there is allusion to urine. And it is written in the hadiths that much of the burden of the grave is because of urine. Let us just paraphrase this statement slightly and say that much of the burden of the grave, that means mortality, is because of abnormalities of the urine, abnormalities of the kidney. And if we understand this, if we accept this, what it means is that we need to focus on kidney health, renal health. However, till recently, we'd been giving Cinderella treatment or stepmotherly treatment to the kidneys. Earlier, we used to focus on glucose control. Then we began focusing on cardiovascular disease. It's just now that we've understood what holistic care is, what comprehensive care is. Each and every organ of the body is equally important. Both the kidneys, the left and right, are equally important. So therefore, we need to focus on improving renal health and reducing renal risk. For this, we have our expert, Dr. Hitesh Punyani, will be joining us. Dr. Hitesh Punyani is a senior diabetologist and physician at the prestigious Chaitanya Cardio-Diabetes Center in West Delhi. I am also told from his CV that he is very fond of women's health. So he is visiting. Yeah, this smile. Why is it that people laugh whenever I introduce them? Dr. Hitesh, could you answer this? Whenever I introduce you especially and other people, why is it that people begin laughing at me?
So bring in some perspective, which very brings in a very spontaneous laugh. Interested in women's health. I mean, that was quite a line.
But isn't that true, Dr. Hitesh?
Yeah, that's certainly. I mean, going in a very generic term. Yes, I mean, because I'm working in a hospital which is doing a lot of obstetric work. So yes, I think that really is absolutely correct.
But coming back to our topic for today is reducing renal risk, enhancing renal health in persons with diabetes. So, Dr. Hitesh, warm welcome. Dr. Hitesh brings to the forum, he brings 2.5 decades of experience in the leading hospitals of New Delhi, private as well as public sector. And he is known for his comprehensive, holistic approach towards diabetes care, something that we try to reinforce in Diabetes Essentials. Dr. Hitesh, warm welcome. Lots of friends waiting for you. There's a lot of friendship and fellowship in Diabetes Essentials, and we look forward to learning from you, sir.
Thank you so much, sir. I'll try my level best. So should I start then?
Certainly.
So I think this is a new platform for me. So this mode, I think we've been doing it on Zoom and Teams. So there's a screen share. I should switch this on? Share screen should be clicked.
First present, then share screen.
Okay.
When you then again share screen, the blue one, the blue bar,
Uh huh.
and then the entire screen. You have to click again. So now you move to on top. You will see Microsoft Edge tab, window, and entire screen. Click on entire screen.
No, let me do it again. Share. So
Yep.
here I go on the share Chrome tab. So
Share entire screen will be written
it's not
on
showing.
top.
Okay, entire screen is there. Yeah. Okay.
Click on that, and now you click again on the entire screen that you see in front of you.
So now I click on share again. Huh?
Yes,
Or on the
yes.
screen itself.
No,
Okay, share.
again, share should be fine.
Chrome has lost permission to capture or to fix it. Go to system preferences. Unlock the screen by selecting the lock in the bottom left corner. Give me a moment, huh? I'll have to, I think, open.
This is actually what happens in the OPD as well. There are so many things to do. You have to look after glucose control, you have to look after the patient's symptoms. Then there are other numbers that the patient is worried about, like blood pressure, cholesterol, body weight. These are issues. And on top of that, to add renal function, that sometimes does become a challenge. We welcome Dr. Vinayak Sharma. We also welcome Zindagi Hatke, a very beautiful name. So, hi, Zindagi Hatke. And a beautiful name, Zindagi Hatke, and also a very beautiful DP. So, that makes me happy and makes me feel young. And then it is tough in the OPD to first of all introduce the concept of renal health, then to ask for the right investigations. When I began practice 25 years ago, 24 years ago, the total investigation for me in the charitable hospital I used to work in was a urine routine, sometimes just urine albumin. Now there are much better quality tests. So we know what EGFR is, we know what UACR is, urine albumin creatinine ratio. These are things we may ask Dr. Punyani about during the discussion. So first of all, you introduce the concept of investigations, screening, and diagnosis. Then you introduce the concept of reno-friendly drugs, whether they are glucose-lowering drugs, blood pressure-lowering drugs, lipid-lowering drugs, or other reno-specific drugs like finrenone. You introduce that concept, and then you ask the patient for regular monitoring. So these are all things that we have to do in the OPD. And apart from that, lifestyle, of course, is a major issue, which Dr. Hitesh will speak about. If you're comfortable, Dr. Hitesh, otherwise uh,
Just
we
give
can
me a
move
while.
to next for you.
And
Yeah. Okay.
uh, I think it should come now. So I'm going to this check Google Chrome and uncheck, then recheck it if there's a. I think there's some problem with my this system preferences. It's not letting me access this. Ani Rasab, no, it's not coming
So if
because I've changed the slides as well. So that will be, you know.
yes, so please mail to me.
Okay, I'll do that. Just give me a moment.
While we wait for the slides, let's begin talking about screening. Now, how do you screen for renal function? That's the first thing. The simplest test would be a urine routine, but that's not very sensitive or specific. The urine routine, however, will help you pick up many things. It might help you pick up a UTI, urinary tract infection, which can be symptomatic, asymptomatic. It also might be, Dr. Hitesh, in the private chat, you'll see the emails to mail it.
Hmm.
Hmm. So you might wish to do a urine routine, but that's not going to uh, give you the complete picture. Though it will help you pick up a UTI, it will also help you pick up, crystal urea, calcium crystals, uric acid crystals. All these have an important role to play in management. Hematuria can be picked up on a urine routine. For the routine patient, however, there are two kinds of tests that are done. The first test will be done for kidney function. So for that, you do an EGFR. We do a serum creatinine. We then use a calculator. These are available free of cost. And with the calculator, you check the EGFR, estimated glomerular filtration rate. It is important to do EGFR because EGFR depends upon age, it depends upon gender as well. So for an elderly and body weight, for an elderly, frail 60-year-old lady, the EGFR will be lower than for a young, normal weight gentleman aged 40 or 35 who has the same serum creatinine. So EGFR will tell you about kidney function. But before kidney function, there might be kidney damage. You might have damage to the kidney. So this damage, if you don't check it early enough, it will be very late by the time you pick it up. And this damage we check with albuminuria. Now you can do a urine routine, you can do microalbuminuria, which is better. That's a dipstick. But again, the most accurate one is a UACR, urine albumin creatinine ratio. We now have point of care testing. Point of care testing, which can help you do UACR immediately in your OPD. So if you have a busy clinic and the turnover is very fast, then you might wish to invest in a point of care machine which will help you check HbA1c, also urine albumin creatinine ratio. And we welcome Mr. Sharma from SGPGI Lucknow. Warm welcome, sir. Today we are speaking about,
So can is my screen visible, sir? Now? Sorry, I'm
yes,
sorry.
it is perfect. And you can hide the hide button in front of you, then that will disappear. The very
Okay.
hide you can
Yeah.
click and yes, no, back to, we have to go back. You find earlier.
It's not coming now.
No, we are saying lots and lots of stuff. Just start all over again, then we'll stick.
Okay. Okay.
So we are speaking of renal function and how to reduce it. And renal function actually does get step motherly treatment in our OPD sometimes, though as a group of physicians, we are improving. Dr. Yogesh Uplenchwar asked this question. We acknowledge it. Is imeglamin safe in CKD, chronic kidney disease? And
Is it
yeah,
visible?
we'll carry on. Yes, perfect. So we'll ask Dr. Hitesh to speak about this towards the end of his talk.
Yeah.
So we are good to go now, Dr. Hitesh. Both the left and the right kidney waiting to listen to you.
Yes. So after this very interesting introduction about this kidney, the whole concept that's as is trademark style, Dr. Kalra has introduced this concept so beautifully, and let me try and put in few slides here to talk about the very basics about the the various methods that where we can use in bringing down this load of urine in the grave, as he explained. So so this is what the basic what we when we are talking about diabetic kidney disease, we know that this is almost universally, almost all over the world. So this diabetes is the single most important factor or single most common reason for uh, for the kidney disease in general and for the end stage kidney disease as well. So over half of the 50% or more of the patients worldwide, when you see them suffering from a kidney disease or end stage kidney disease, so more than 50% of those people are diabetic population. So it is a very complex and heterogeneous disease and has numerous pathways which are involved in its etiology overall. So we know that the primary reason is hyperglycemia, and how hyperglycemia in turn leads on to this is by producing various advanced glycation end products, and reactive oxygen species. Along with it, then there is also and because though the pivotal role is being played by hyperglycemia, but insulin resistance and hyperinsulinemia, they also bring on their inflammatory effects, and that is the reason that we tend to have some pathogenic difference in the kidneys of the patients when we see suffering from type 1 or type 2, because in type 2 insulin resistance is also playing a major role. And then there is overall this complex interplay of alteration in glomerular hemodynamics. When we talk about alteration in glomerular hemodynamics, what we mean is there is glomerular hyperfiltration, which is very much evident especially in the initial part of the diabetic kidney disease, and later on there is also the an inflammatory and effects and tubular atrophy and fibrosis as well. So I'll just try and explain very briefly. So what's happening behind the scenes when we are seeing when these the seed is being sown for the manifestation of this disease. So what happens initially is that there is the once the diabetic milieu sets in, so there is this renin angiotensin system gets RAS system gets activated, and because of the activation of this, so various there is disturbance in the afferent as well as and the efferent arteriolar tone. This there is a mismatch there. So, because of the presence of various vasodilators, whenever this renin system is activated, you have increased levels of ANP levels or atrial natriuretic peptide. We have increased levels of nitric oxide and prostanoids. So, all these are the vasodilators at the arteriolar, efferent arteriolar level. So, they try to reduce the tone and they thus try to increase the GFR. Simultaneously, we have increased vasoconstrictors as well in the form of angiotensin, in the form of various prostanoids as well. These vasoconstrictors, what they are doing is they are acting on the efferent arterioles. So what's happening is efferent is dilating, efferent is constricting. So overall there is glomerular hyperfiltration, and this glomerular hyperfiltration, when it's present for a long duration of time, eventually leads on to the sclerosis of the glomerulus, or the sclerotic kidney impact is being produced by this. So apart from this, second pathogenic mechanism is operating at the level of the tubules. The first one we discussed at the level of the glomerulus. The second one is at the level of the tubules. What's happening at the level of tubules is initial part of this disease. We know that when there is moderate hyperglycemia, more than 180 milligrams of blood glucose, so there is upregulation of SGLT1 and SGLT2 receptors in the proximal tubules. What they do is they this upregulation tends to reabsorb glucose, but along with the reabsorption of glucose, because it's a sodium glucose co-transporter, so there is increased absorption of sodium as well. Now, when there is increased reabsorption of sodium, lesser sodium is going to the distal tubule or macula densa. So when there is lesser sodium is going there, so it has this the system what we call as tubuloglomerular feedback is being impaired, which in turn leads to further decrease in the afferent arterioles. So this is basically the concept where in which the diabetic kidney disease is being set in. So once we know the basic etiology behind or the pathogenic mechanism behind this disease, so now the question is how can we target this, or how can we reduce the burden of this disease? What actions can we take? So of course, because it's hyperglycemia is the main pivotal point, and is the leading point, which is triggering all these mechanisms. So there is no doubt, and we have ample evidence right from UKPDS that there is this improvement in glycemic control gives us very very good amount of benefit in terms of reducing this overall endpoint of one of the complications of this disease. Then second very important point again is reducing blood pressure. Now, reducing blood pressure, it sounds very simple, but it is one of the major contributors of diabetic kidney disease or the progression of this disease. And there was a lot of conflict amongst the various, or disconcordance amongst the various societies about the target blood pressures, especially in people those who have developed this moderately severe albuminuria or severe albuminuria. So the target now, even in 2023, I think ADA in January revised the blood pressure guidelines, and they've very clearly stated that those patients who have CKD, so they want the blood pressure to be less than 130/80. Earlier, American Heart Association, along with the ACE, American Association of Cardiology, this ACE society, they were already recommending the lower targets. But now even AD is saying this. But in again, we have to be very mindful of the fact that this blood pressure reduction should be without any complications, without further increasing morbidity, without further increasing the risk of hyperkalemia. So if it is easily tolerated by the patient, then reducing blood pressure has a very distinct benefit. And again, if we talk about reducing blood pressure, the choice again is very clear, as we most of us have been doing this for many years now. So the ACE inhibitors or the ARBs are the drugs of choice. Initially, they tried to combine these two as well. They decreased proteinuria with this combination, but overall mortality was increasing. Overall risk of hyperkalemia was increasing. So if we talk about reduction in blood pressure, so ACE inhibitors, ARBs are initial drugs of choice. But if you have to further add on, because if you're not able to manage just with the ACE or ARBs, then the dihydropyridine calcium channel blockers, they need to be brought in. So they are again helpful by reducing the blood pressure in reducing the renal endpoints. And then we have other events like managing lipids and addressing obesity. So we'll touch base upon these as well. We have when we are talking about blood pressure, again we'll just revise those two or three things. One is the target is less than 130/80 if it is achieved without producing any complications or morbidities, increasing morbidities. ACE-ARB are the preferred drugs in this. And then if ACE-ARB we need to supplement them, then we have to bring in calcium channel blockers. Second is, then we've talked about the improvement in the glycemic control. And before the event of these SGLT2 inhibitors, we were just focusing on A1C levels. So the target A1C, most of the cases we know that if a patient is in early stage of diabetes, it could be 6.5. Those in advanced maybe more than 15-20 years, maybe less than 7 should be a good target. And similarly, in patients those who develop diabetic kidney disease in form of moderately increased albuminuria or severely increased albuminuria, which is micro or macro albuminuria in other terms. So there again, the this we need to have a very uh, aggressive approach in terms of glycemic control. In that sense, aggressive means, I mean, then again the target is around 7 or less than 7. Again, with the caveat that you can achieve this target of 7 or less than 7 without producing much of hypoglycemia or other side effects with the drugs. But now we have this new class of drugs, which is not so new now. In fact, it's been available to us for almost 9-10 years now. So, this is the SGLT2 inhibitors. And now gradually, for last few years, the evidence in terms of reducing renal outcomes has been very robust. So whether we talk about the Canvas program, and then they had this extension with canagliflozin in the form of Credence study, where they showed very good improvement in the renal endpoints with canagliflozin 100 milligrams. Then we had this DAPA CKD with dapagliflozin again, where they showed very good reduction in renal endpoints with dapagliflozin of 10 milligrams per day. And then we had this AMPA kidney as well after the AMPA reg outcome, and they again showed very good benefit. When we are talking about SGLT2 inhibitors, again, we what they have seen is that whether the patient has diabetes or patient is non-diabetic kidney disease, so they are effective in both the scenarios. And again, whether patient is having moderately increased albuminuria or severely increased albuminuria, so the relative risk reduction remains the same, but absolute risk reduction is much better in those patients who have severely increased albuminuria. So those patients who have severely increased albuminuria, or who have more than 300 milligrams of protein excretion per day, so these are the patients where SGLT2 inhibitors, they produce the maximum benefit. So this is and this is irrespective whether we are using dapagliflozin, whether you use canagliflozin, or whether we are using ampagliflozin. So either of these three drugs in this class, they have shown very good benefit in terms of reducing the renal risk. And once they are reducing the renal risk, so they also have a very direct impact on the CV outcomes, and we know that whichever intervention brings down the renal risk has a very indirect or very huge impact on reducing the overall CV outcomes as well, because renal risk is very directly proportional to the overall cardiovascular outcomes or adverse cardiovascular outcomes as well. So, the as we see the guidelines again, because we have ample evidence, so they are also recommending this class of drugs. Once the patient is a diabetic and he has, I mean, yeah, any evidence of diabetic kidney disease, so such patient is always a candidate for SGLT2 inhibitors. And SGLT2 inhibitors, apart from SGLT, the other class that is available to us is GLP-1 receptor agonists. So they again tend to have a good benefit, especially we have good evidence for liraglutide and dulaglutide, and both of these GLP-1 receptor agonists, they have also shown good benefits, but their benefit is mainly in terms of reducing albuminuria. So we have to be mindful of this. And so GLP-1 receptor agonists, though beneficial, SGLT2 seems to have some edge in that. So the good part is that earlier we were just reducing blood glucose levels, we are bringing down HbA1c and getting good evidence, good outcomes in terms of renal endpoints. So there was the very decent reduction as we saw in UKPDS in terms of renal outcomes. But in addition to that, now we have some these two classes of drugs which not only reduce the CV outcomes, but they also have very good evidence in terms of if we use them judiciously in terms of CV outcomes. Similarly, we talk about the very touch base on the mechanism where how the SGLT2 inhibitors help. So as we discussed in the pathogenesis or pathophysiology of the evolution of the diabetic kidney disease, so this is again one of the main reasons is that what there was upregulation of SGLT2 inhibitors, as we saw in the moderately increased hyperglycemia because of upregulation of those receptors. So there was increased reabsorption of sodium. But once you start using SGLT2 inhibitors, so this reabsorption of sodium is inhibited. More sodium reaches macula densa, and thus it restores the tubuloglomerular feedback mechanism by constricting the afferent arterioles. Thus, it decreases the glomerular hyperfiltration, which was the main culprit in altering the glomerular hemodynamics and producing this kidney disease. So now we have another molecule which is non-steroidal mineral receptor antagonist, which is finrenon. And earlier to finrenon, they tried using L-decton, which is a steroidal mineral receptor antagonist. We know that. But the problem with the L-decton was, though it was decreasing albuminuria, but it was simultaneously increasing uh, potassium, especially in patients those who were on ACE or ARBs, and most of these patients are already on ACE or ARBs. But when we studied this drug finrenon, so there was very clear cut indication which came out that those patients where albuminuria is more than 30 milligrams per day, despite being on ACE inhibitors or ARB along with an SGLT2 inhibitor, there is a very good evidence that this non-steroidal selective MRA, wherever available, it has a potential to reduce the uh, renal endpoints. And the two indications which we have to be very careful when we are using finrenon is that the patient's serum potassium should be less than 4.8, and his eGFR, as of now the data is for eGFR more than 25. So apart from glycemic control, apart from um, uh, uh, having a good control on blood pressure, so there are we have to attack this problem from multiple angles. So one other one is the lifestyle intervention and obesity. There are lots of studies which have shown that the diabetic patients who are obese, the renal disease tends to come in early, and it tends to worsen at a faster pace than as compared to the non-obese population. Now, there are various the reasons that they have explained about the glomerular hyperfiltration which comes in patients on obesity, but it's very clear that those patients who lose weight or those who are already obese, and when they lose weight, it has a very good impact in terms of reducing albuminuria, and to some extent has some impact in reducing the hard end renal endpoints. So this is again this could be one of the mechanism why these GLP-1 receptor agonists have shown good beneficial impact on, because they are known to produce some significant weight loss, and they are also producing their main impact in reducing the albuminuria, which is again very directly related to the weight loss, as we've seen in a obese population when they are being given those lifestyle interventions and brought under weight control. And not just obesity, two more things which we at times I would like to highlight is, so another thing is the management of dyslipidemia. So dyslipidemia, again, we have to be mindful of two things. One is that whenever the patient has CKD, unless and until it is end stage renal disease, there's always a benefit by treating the high cholesterol, high lipid levels. So by treating them with statins, preferably atorvastatin and fluvastatin are the two statins which are considered to be relatively safer in CKD, because you don't need much dose alteration in these two. So atorvastatin is freely available, so it is one drug which brings down the CV endpoints in these patients, and to some extent has some help in reducing the renal adverse renal outcomes as well indirectly. But patients, those who have end stage renal disease or ESRD or ESKD patients, in these patients the use of statins is not considered to be much of a benefit. And last factor is again the factor which I would like to discuss is smoking. I mean, smoking is something which should be very seriously discouraged. Smoking has again similar, attacks the same pathogenic mechanism as hyperglycemia, along with the oxidative stress that hyperglycemia brings in, endothelial damage that hyperglycemia brings in. These are all accentuated, or these are all magnified many times if the patient is smoker, and thus these renal various outcomes in be it in terms of micro macro albuminuria, or in terms of doubling of your serum creatinine levels, or reaching the stage of ESKD or end stage renal disease. They are all very adversely impacted if the patient continues smoking. So stoppage or quitting of smoking is almost the most one of the most essential parts if the patient with diabetic kidney disease is already a smoker. So with that, I think I would just end my talk, and would like to have discussion with Dr. Sanjay sir and 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 people who have joined us today.
Thank you, Dr. Hitesh. Lots of people listening to you, lots of comments and questions. Thank you for making a very difficult topic seem so simple and straightforward. Uh, Dr. Anshul Singhai, who is a diabetologist from Bhillai in Chhattisgarh, thank you specifically for highlighting this renal risk, because this is something that is often ignored. One question is from Dr. Yogesh Uplenchwar. Is imeglimin safe in chronic kidney disease?
Imiglibin, I think we I'm not studied that much in our setup, because imiglibin, we don't have any good RCTs available to us. I think maybe you know it better, sir. So I'll just pass it on to you if you have any
Yeah,
idea
one
about.
of the advantages, Yogesh, is that you can use it in CKD. If the EGFR is below 30, a dose of 500 milligram OD. If the EGFR is between 30 and 45, then or 35, 30 and 60, then 500 milligram BD. I personally do write 500 milligram twice a day or once a day, depending upon the EGFR. And sometimes I write 500 milligram at night. This is in patients where I'm struggling with fasting glucose control. And I feel afraid because of the renal dysfunction. I feel afraid of increasing the dose of insulin. I feel afraid of giving a sulfonylurea. And still the fasting is not coming down. Then the tricks up our sleeve are, first is imeglimin, and the second one is to give a very light sedative, depending upon the patient's need. Sometimes you can get away even with a tablet of melatonin. That also improves sleep quality, and then you will find that the fasting glucose comes down. Dr. Jenna Ortega greets you, Dr. Hitesh, and she notes your interest in various types of health. But the challenge that is being shared is a 50-year-old patient with diabetes for 7 years. Now, glimepiride and metformin, 1 plus 500 milligram BD being taken. A1C is still 8.5. So creatinine is 1.7. That's the issue now. Now, how do we proceed? 8.5 is the HbA1c. What do we do with the oral drugs? Do we think of insulin?
I think yes, insulin is sure shot an option because we are very far away from glycemic goal. If you want to, she's 50 years, we would like to keep HbA1c around 7 because her creatinine is also going up now. So there are two things here. One is we need to address the glycemia, hyperglycemia, and second is we need to have some renal protection as well. So in this case, again, we would like to start SGLT2 inhibitor as well, but we expect that SGLT2 inhibitor will bring down the renal risk to some extent, but we won't be able to reach the glycemic goal with because it's 8.5, so we expect reduction of around 1.1 with SGLT2. So we might need to supplement something. Now the choices are that either we increase the dose of glimepiride, which we would like to avoid because the patient is already having worsening of renal function. We know that sulfonylureas tend to increase hypoglycemia in such patients. Second is that we either bring in some along with this DPP4 inhibitor, which is safer in this creatinine range, which is more. Either we bring cut the dose of sitagliptin or we introduce the normal dose of linagliptin. So what I would do is I'm not in a hurry, so I would like to bring in some lifestyle modification, reinforce it, and add SGLT2 as of now, and wait for about 6 weeks to 8 to 12 weeks and see how her HbA1c is behaving once we have put in on SGLT2 inhibitor. And if we are beyond 7, then maybe then we can bring in insulin as well in such a patient, or DPP4 inhibitor again.
In
It's
the
it's
meanwhile, Dr. Hitesh, I did a quick calculation for the EGFR at a creatinine 1.7. If this patient is a gentleman, then the EGFR is 49. And if it's a lady, then the EGFR is 36. So would this make a difference whether this patient is a lady or a gentleman? Now EGFR is going down to 36.
but yeah, it could have about 6 months back, but now we have good evidence. We have AMPA CKD, which was done in patients with 20. GFR of 20 was the cutoff in these patients, and even in patients in DAPA CKD, again it was 25 EGFR was the cutoff in those patients. So if it is 36 or 48, 49, I think we are good to go with the SGLT2 inhibitor.
Any acute diseases or any past history that you would like to exclude before you start SGLT2 inhibitors?
So two things, sir. I mean, one is of course, if there is history of, we know that genital infections, there is almost 2 to 4 fold increase in these patients, and especially in females, the prevalence is a lot higher. So if there is previous history, then that prevents us from using this. Second is we have to be mindful of about the euglycemic ketoacidosis in such patients. And third is that if they're using certain, because creatine is going up, they might be using some painkillers as well, and the SADs that are very commonly used. And if you add SGLT2 inhibitor along with it, so that there can be further worsening. And so hydration levels and insulin and endogenous or exogenous insulin levels, that insulinopenia should not be there, hydration should be good. So these are the two things, apart from history of previous genital infections, that we should be mindful of.
And do be aware that even a single episode of upper UTI, like pyelonephritis, is a contraindication for SGLT2 inhibitors. Dr. Singh has a question. Sir, many times in practice, we have to use diuretics as an antihypertensive. Is there any difference between the various diuretics? Which is the most metabolic friendly?
Diuretics in hypertension. So
Yes.
diuretics and hypertension, we have these three that we have evidence of. One is we know chlorthalidone, hydrochlorothiazides, and then we have third is the loop diuretics, and fourth one is our aldectone as well. So these are the four categories of drugs. These are the three categories of drugs which are available to us. So the best evidence, I think, even in terms of risk reduction, because the primary motive when we are using a drug as a antihypertensive is the hard endpoints of CV outcomes. So in those terms, best evidence is with chlorthalidone, to some extent with hydrochlorothiazide as well. In cases of resistant hypertension, we have to fall back on aldectone as well. And fourthly, in patients, those who are retaining a lot of fluid, or those who are in congestive heart failure, or in incipient or early congestive heart failure, or there is a lot of water retention in those patients, then furosemide can also be used. So this is what the various diuretics in preference should be.
Thank you. Dr. Ortega continues the discussion in a different way. Patient has got chronic kidney disease and patient has got pedal edema. Can I use furosemide or torsemide? What is the indication for loop diuretics in medical practice? So let's talk about indication for loop diuretics in medical practice, and then we specifically answer the indication for loop diuretics like furosemide or torsemide in persons with diabetes.
So whenever a patient has pedal edema, now we have to evaluate this, that this pedal edema could be because of some concurrent drugs. Maybe amlodipine can lead to this. Some other drugs can lead to this. So pedal edema, if it is not because of drugs, and if it is because of retention, water retention that's happening because of the chronic kidney disease, then this is one of the evidence that the patient is overall retaining more of a fluid in, and then what we need, we don't need to start loop diuretic straight away. We need to monitor the patient's weight in such cases. And if you find that in consecutive weeks, maybe in next 3 to 4 weeks, patient has gained another 2 kgs, so that's a very clear cut indication that you need to start loop diuretics. Second is, if patient is already feeling some shortness of breath, again that's a very clear cut indication with pedal edema that we can straight away start with the loop diuretics. But whenever we are starting loop diuretics, then we have to be again cognizant of the blood pressure that the patient is maintaining. Usually in these patients with CKD, most of them have rather higher blood pressure, so it's not much of a problem in these patients, but still we have to be very careful. And second, whenever we start loop diuretics, so there could be some worsening of blood urea and creatinine. They tend to go up initially in many of these cases, and then there could be some electrolyte abnormalities in terms like because hyponatremia. So this is again is very common with this. So again with these things in mind, and if we feel that patient is is gaining weight along with the pedal edema or having breathlessness, then that makes things easy for as an indication for loop diuretic.
Thanks. You've spoken about thiazides, that was chlorthalidone, hydrochlorothiazide. We also have thiazide-like diuretics like indapamide, which have a strong role to play in practice for both blood pressure and for kidney protection. Then we spoke of Dr. Jana discussed torsemide and furosemide, which are loop diuretics. And now Dr. Anshul takes the discussion forward. He says we have other diuretics as well. Uh, Example would be spironolactone, finrenone, eplerenone. These are MRAs, mineralocorticoid receptor antagonists. So, what I what are the indications for using any of these in practice? Do we use them as a first line antihypertensive? Right now, Dr. Hitesh, let's stick to blood pressure lowering. Would I want to use spironolactone as a first line, second line, or third line blood pressure lowering drug? From a blood pressure point of view, specifically, when would I use it?
So spironolactone, sir, the guidelines is state very clearly, and if we use it, we find it very effective as well. But when we are using three classes of antihypertensive drugs, and blood pressure is still not within the goal, it's labeled as refractory hypertension. And the first drug to be used in such cases, if there is no contraindication, is spironolactone. The only problem with spironolactone is it produces very good antihypertensive effect. When we are struggling with three drugs and you add spironolactone, you get very good results most of the times. But the only problem is that we have to be very mindful of the renal function, very mindful of the other drugs, because many of these patients have comorbidities. And especially if we are talking just about hypertension, most of these tend to be on ARBs or ACE inhibitors as well. So ACE ARBs along with spironolactone, and if there is mild decline in renal function, so potassium tends to go up very early. So that's the problem basically with the spironolactone, and to some extent that was the problem with aprenon as well, because it was non-selective.
So, if you want to use spironolactone for blood pressure, it's quite clear. If you have resistant hypertension, that means you're not able to control BP with three drugs, three classes of drugs. Then you will take charge of it and be mindful of hyperkalemia. So, because you will use it only after three drugs, usually there will be an ACE inhibitor or ARB in place. But when you are giving spironolactone along with ACE inhibitor, then the chances of hyperkalemia go up slightly. So we have to be mindful of that. Now let's change tack. We are still on MRAs. Spironolactone has a relatively higher risk of hyperkalemia. Finrenone is the new kid on the block. This has the minimal risk of hyperkalemia. In between, we have eplerenone. Eplerenone would be the drug of choice for heart failure. But finrenone is something that we will use for renal risk reduction. And this answers the question from Dr. Jenna. If urine ACR is 70, serum creatinine is 1.7, you have already optimized glucose lowering therapy. Dr. Hitesh spoke about adding SGLT2 inhibitor if there is no contraindication, and then thinking of insulin. You've already given an ACE inhibitor ARB, and you want to improve renal function, you want to prevent further damage. Then the drug of choice is finrenone. You can start if the potassium is up below 4.8. You can continue if the potassium goes up to 5.0. So a comment and a praiseworthy comment actually from Chhattisgarh. Sir, your presentation is very thorough and thought-provoking. Thank you, and please come more often on Diabetes Essentials because we want better and better speakers like you. हम बोर हो गए हैं पिछले स्पीकर को सुन सुन के इतने हफ्तों से. Your comments, Dr. Hidesh.
Comments किस पे सर?
On this comment from Dr. Anshul, your presentation is very thorough and
No,
thought-provoking.
no,
You
it's,
should
it's,
become
it's
more
it's all about,
frequently on.
no, 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 no. I mean, this is all about you. You know, you.
So it's for you. So we want you
I'm
to
doing
come
more.
more frequently.
No,
But we'll cut back to the questions. There are lots and lots of questions, Dr. Hitesh, waiting for you today. When do you suspect for CKD in a diabetic patient, sir? So type 1 diabetes, type 2 diabetes, we will do a routine screening annually. That is a separate matter. But sir, what are the symptoms? First question. What are the signs? Second question. And what are the surrogate laboratory abnormalities? Third question, where I would want to do a more aggressive kidney function and structure screening.
so one is, I think that if we talk about symptoms, so fatigability is one, which is a very vague symptom, but is actually sometimes a very surrogate symptom of kidney disease, underlying kidney. Second is, when we apart from fatigability, we tend to see because that also contributes, the patient tends to be anemic as well, if you're talking about signs. And the blood pressure levels, they start showing sudden increase. Though those who are normotensive, they're becoming hypertensive. Those who are hypertensive, they are going to from stage 1, stage 2 to stage, I mean, a stage higher. So these or as we talk, that any evidence of fluid accumulation in the body, like pedal edema. So these are few of clinical, in terms. But if you're getting somebody screening for diabetic retinopathy, and you're getting some evidence of retinopathy, then that again raises a red flag that we should be now screen him for nephropathy more carefully now, in these patients, because they also tend to coexist, nephropathy and retinopathy. And then apart from nephropathy and retinopathy, um, then of course we have these various laboratory parameters. And in laboratory parameters, again, if you're talking about surrogate, to low hemoglobin, normocytic normochromic anemia is one of those. Then again, increased ACR, as we are talking about. And then again, a very direct kidney function tests, like your blood urea serum creatinine and EGFR, that we are measuring these days. So this comes to my mind. I think, if you can add on
Let's
to
just
this.
repeat that. Symptoms, easy fatigability, a complaint of premature aging. The patient says, I was fine until recently. Now I feel old, I feel aged. Then you ask the patient, do you think that's from a mental cognitive point of view or a physical point of view? So patient says, maybe both or more physical. My mind wants to work, my body doesn't support. That would be a general, not very specific, but you will look for thyroid, you will look for renal function. Edema, swelling feet, weight gain, weight loss, loss of appetite. These are factors. And then retinopathy, like Dr. Hitesh mentioned. Other thing would be sudden rise in blood pressure. For the past so many years, patient has been well controlled on one or two tablets or one or two classes of drugs. Now suddenly we've gone up to three classes of drugs and BP is not getting controlled. That would be a challenge where you look for nephropathy and anemia, normocytic, normochromic, high triglycerides. Uh, Renal failure, CKD, is a common cause of secondary dyslipidemia, so that we must remember. Sir, more questions. Dr. Jenna says GLP analog is costly. To reduce the renal risk, what other drugs can I use? And you've mentioned some of them.
So again, sir, I mean, we are already using for hypertension ASARBs. Then we want to bring in SGLT2 inhibitors as early as possible. And if we can't use GLP-1 receptor agonist, then if there is a, we are already using SGLT2 inhibitor, and patient is potassium level is less than 4.8, and if his EGFR is more than 25, I think then Findrinon is again a molecule that we have now, which reduces the not just the renal outcomes but also the CV outcomes as well to a great extent. So I think
Dr.
these are
Jenna,
apart.
yeah, Dr. Jenna, Dr. Yogesh, and Dr. Deepak, many questions are coming up regarding Finrenone. So, to reduce the cost, of course, 10 milligram OD is what you begin with. And then after a month, you can go up to 20 milligram OD if the EGFR is maintained and if potassium does not rise. But many times we use 20 milligram half tablet that reduces the cost by around 40-45 rupees. Dr. Jenna asks about starting, so that is 10 milligram OD for Finrenone. Maintenance, if the EGFR is below 45, you stick to 10. If the EGFR is above 45, you try to increase to 20 milligram. You can check sodium potassium once at beginning and then after a month. After that, every 2 or 3 months should suffice. You don't have to worry too much. Once again, another thank you for you again from Chhattisgarh. But the questions are coming still. So, Dr. Hitesh, we can't let you leave. Uh, Dr. Dr. Anshul says, can I give imeglimin and metformin at the same time together? Is the GI tolerability okay?
So Amigliment, sir, I've not used much, not much of X. I think I'll leave it on, pass it
We
on.
can, yeah. Out of 10 patients with one Anshul, you might have GI disturbance, but in general, it is much less than what you see with metformin, much less. And when you see the size of the tablet, metformin 500 milligram is like huge as compared to imeglimin 500. So the tablet looks smaller. It is smaller. It's not lighter, but it is smaller, and so patients accept it more happily. Dr. Deepak Rai Singhani from Rai Singhani Hospital says, Sir, in your practice, do you use taurine, acetylcholine, and alpha keto analogs routinely? Do they have any evidence base?
No, I mean we have seen them in a lot of prescriptions, and the problem is, at times the compliance with these drugs is also amazing because patient wants to get a drug जो kidney की दवाई कौन सी है इसमें.
Mhm.
So we keep on emphasizing, most of the times that if you maintain your blood pressure, if you maintain your blood glucose levels, your HbA1c levels, and you have good weight reduction along with smoking cessation and lipid control. So these are the five factors which are almost 98% of the management that we have in reducing the renal risk. But still the question is, I mean, ये kidney की दवाई तो कोई भी नहीं है इसमें. So this is where these are cashing on, but I whatever evidence I have seen, it's not been very convincing one with these.
A much better drug use of money would be Finrenone. And
Yeah.
also, when you are giving a statin should be given to everybody with the chronic kidney disease, everybody, irrespective of cholesterol level. When you're giving a statin, an ACE inhibitor or ARB, or even a drug like indapamide, you can point out that yes, other people get it for blood pressure. We are giving you for renal preservation. So you have to add the word renal preservation to whatever you're prescribing, and then you will find that adherence will go up. A question from Dr. Rajdeep Biswas. Many people say, and our WhatsApp university says that metformin damages the kidney. Is this correct, sir?
So metformin, there is first of all, actually this is completely incorrect statement. So metformin does not have, if at all, if metformin has any impact, it's a beneficial impact on the kidney function. By reducing hyperglycemia, of course, and by some of its pleiotropic effects as well. And the only reason is that because of it doesn't worsen the renal function in when we withdraw metformin in patients with high creatinine or poor EGFR levels when they are very low. It's because of the risk of lactic acidosis that comes in with this. So there is if at all there is any proof, there's very good amount of proof in favor of metformin in favoring the renal function to a great extent. And now these days, there is a lot of work which is going on in metformin, which is off label, but is also proclaimed to increase longevity as well. So there is a very famous Harvard professor, this who's written a book with a lifespan. He has put his entire family, and he himself is on metformin, despite being he's not a diabetic. And his study on rats and few other things shows that there is a lot of beneficial impact in overall. So metformin, to cut it short, I mean, it's a beautiful drug. And I think that we should not avoid attaching these notions to such a brilliant drug that we have.
If the EGFR is above 30, you can continue. If the EGFR is above 45, you can initiate. And
Yes.
metformin itself is not nephrotoxic. Sir, a comment from the audience is कि sir 10 बज रहे हैं, भोजन की बेला है, and we still have more than 10 questions left. Are you good to go? Good to continue, sir?
Yes, yeah, yeah, I think I'm okay.
So lots of questions still pending. Dr. Jenna shares another case, 45-year-old person, type 2 diabetes, on insulin twice a day, 20 BD mixtard, plus metformin, plus glimepiride. So the patient is already taking 2 doses of premixed and glimepiride concurrently, and HbA1c is 9. That means perhaps we are over treating, or we are treating the wrong way. For this particular patient, Dr. Jenna, I would advise that we request the patient, we will shift him or her to basal bolus insulin. So we will request the patient, we are giving you 40 units per day. We are also giving 4 milligrams of glimepiride. Why don't you allow me to change to 45, 55, or 60 units of insulin per day, but let me divide in 4 doses. So maybe regular human insulin, 10 units 3 times a day. That's 30 units. Plus 20 units of a basal insulin, which can be glargine, it can be degludec. We give that at night. We stop the glimepiride. We increase the metformin from 500 twice a day. We can go up to 1000 twice a day, or 500 3 times a day. And we also must add an SGLT2 inhibitor if there is no contraindication. With this, you will find that glucose levels will begin to fall. How will you counsel the patient? You will say within 3 or 4 days, you will get a feeling of well being. You will symptomatically feel better mentally, cognitively, physically, professionally, personally. In all spheres of life, you will begin to feel happy. Madam, I promise you, next time you come back, you will come back with a smile on your face. That's what Dr. Hitesh does in his OPD. Yes, he does that. So, so you have to counsel, you have to give a reality check. The symptomatic relief will occur within 3 or 4 days. Why am I so confident? Because insulin is the most potent anabolic hormone in the body. You'll get a feeling of anabolism. After 6 or 7 days, 8 days, the postprandial glucose will come down. So you can tell your patient fasting might remain at 200, PP will come down to 240, the excursion will come down to 40 instead of 74 or 80 or 90, whatever it is now. And then after 10 to 15 days, your fasting will also come down. Why is this? Because the basal analog that we are giving at night is going to act slowly. It will take 4 or 5 days to achieve steady state. Once you explain this to the patient goes back very happy, doesn't come back and doesn't argue with you when he or she comes back. And within 6 weeks, you're able to control glucose. And then you can try to de-escalate to 3 injections a day, rapid acting, and pre-mixed at night. Or you can de-escalate directly to 2 injections, what we are giving now, pre-mixed. We will have increased the metformin and SGLT2 inhibitor. We will have stopped glimepiride. But Dr. Jenna takes this discussion forward, what I discussed just now, Dr. Hitesh. She says, now when creatinine goes up, hypoglycemia occurs. But I struggle in my practice. If I reduce the dose, then glucose goes up. If I increase the dose, patient goes in hypo. So some tips and tricks from your practice, sir. How do we balance?
So one is, I think, one of the best ways out is that basal bolus provides a lot of balance. And second, I think what we find these days is it practices in such patients, CGMS helps a lot. So if we use CGMS, we tend to see the patterns in a much better manner. How much they are related to the dietary this thing, how much is it nocturnal, how much is it in the daytime, how much is it symptomatic, how much is it silent hypoglycemic unawareness, how much is it there in these patients. So CGMS is very helpful converting to from premix to basal bolus always helps, because of a lot of flexibility that comes when we are switching these patients to basal bolus. And thirdly, then again, by using or avoiding drugs like sulfonylureas in this category of patients, again gives us a lot of benefit. And bring in, if there's no contraindication, drugs like SGLT2 inhibitors, to some extent DPP4 inhibitors as well, though they may not be, because they're also to some extent insulin dependent action, may not be very beneficial in terms of anti hyperglycemic effects. But still, I mean, they still have a balanced and this lesser of hypoglycemia. And so both SGLT2, because of their various other beneficial impacts on kidney disease and CV outcomes, DPP4 inhibitors because of their safety in terms of hypoglycemia, bringing it to basal bolus, and along with the CGMS, I think these are the few things that come to my mind right away.
We can counsel our patient that there is a difference between speed and velocity. Speed means running fast. So let me not chase your glucose levels. Velocity means, of course, running fast, but in the right direction. So our final aim is good health, good outcomes. So we'll keep on increasing the doses slowly, and we'll try to avoid ourselves from coming into this vicious cycle. Dr. Hitesh, we are mindful of your time, your expertise, your experience. One last question before you leave, and I will continue the discussion. We have many questions left. This is from Dr. Rai Singhani. Sir, could you just give us a simple message? Serum uric acid, when to treat, when not to treat?
Uh, Serum uric acid is again uh, topic, which I find that it's one of the most overtreated disease that we see, hyperuricemia. So if you have asymptomatic hyperuricemia, so then there's a very good evidence that even if you don't treat, it's different in males and females. So in females, there is 1 point, almost 1 point difference. So in males, if it is around 9.5 or 10, even till that levels, there are guidelines which say that we can avoid treating this asymptomatic hyperuricemia. And in females, if it is still 8.5 or 9, I think the cutoff, so we can avoid using the treating the asymptomatic. So we don't need to treat the lab values of hyperuricemia. Uric acid is again indicator of this metabolic syndrome. Again, the common seed it's a part of that common seed hypothesis that we tend to talk again and again, that these various blood pressure, your hyperglycemia, your obesity, this CRP levels, uric acid levels, they go hand in hand. So working on the lifestyle, it's always indicates that it's one of the surrogate markers of a sedentary lifestyle as well. So this is what, if the patient is symptomatic in terms of, he has a history of gout, of course, that's a very clear indication. Or if there is underlying urolithiasis or nephrolithiasis, which could be somehow related to uric acid, this thing, then again, that tends to bring down the threshold at which we use, but not certainly at the level 7, 7.1, 6.8 that we have seen being prescribed uric acid. This is something that I'm but Sanjay sir can further highlight on this.
So, thank you, Dr. Hitesh. We thank you for having shared your expertise with us. And on behalf of everybody who has logged in, we hope to see you again more frequently on Diabetes Essentials as well as other platforms. Thank you,
Thank you,
sir,
sir.
for being with us.
Thank you.
I will
Thank you
continue
so much, sir.
with the discussion.
Thank you, sir.
Indapamide was a question we can use as a diuretic. It is actually one of my favorite diuretics. The risk of electrolyte disturbance is much less with it. Interstitial nephritis I have not encountered. Uh, Indication specific for indapamide over other diuretics, not too much. All the thiazide like diuretics will be the same. Indapamide does have better quality data regarding long term advantages in renal function. So like we speak of glycemic memory, metabolic memory, glycemic legacy, there is a renal legacy with indapamide and with perindopril, long term effect which is not there with the other drugs. Anemia in CKD, our target should be to keep HbA1c at around 10 to 11. If you increase hemoglobin too much, that also increases mortality. So it is U-shaped curve. We want to keep hemoglobin around 10 to 11. And erythropoietin and erythropoietin analogs are used provided that serum iron is normal. So before you give erythropoietin, you have to do a serum iron studies. If iron is normal, ferritin is normal, transferrin saturation is normal, then we'll give erythropoietin. Erythropoietin is required to improve hemoglobin. It is also required for quality of life. It is an anabolic hormone. And sometimes in chronic kidney disease, if you have subclinical hypothyroidism, TSH of 6, 7, 8, otherwise you may not treat. But if you have CKD and anemia, normocytic normochromic, then you will give thyroxine in low dose. That will increase the uptake of iron. It will improve hemoglobin levels. And you will find massive improvement in quality of life. For vegetarian patients, too much of diet restriction is not needed for uric acid or for renal dysfunction. You can tell your patient not to take too much of paneer and dal together at the same time. But otherwise, even if they eat lots and lots of paneer and cheese and dals, they will very rarely cross 1 gram per kg per day. It is quite difficult to cross 1 gram per kg per day of protein with an Indian vegetarian diet. The dal with the maximum protein content in India at number two is soya bean, white soya bean. At number one is a dal known as bhat ki dal, bhat. The English word would be black soya bean. It comes from Uttarakhand. So you can try that. It is tasty. It takes slightly more time to cook than the other dals. And Dr. Anshul says for Dr. Jenna's case, basal bolus insulin, metformin, SGLT2 inhibitor, and you can add DPP4 inhibitor. Yes, that's true. Linagliptin will have good results on renal function. DPP4 inhibitors, however, will help if the patient has got uh, diabetes for short duration of time and also uncontrolled diabetes for short duration of time. Now, this particular patient that Dr. Jana shared, the patient was already on glimepiride 4 milligram and insulin 40 milligram, and glucose is still 9%. So probably there is not much stuff left in the beta cell. So therefore, DPP4 inhibitors may not be very effective, though they will help the kidney. Linagliptin will help the kidney, but from a glucose lowering point of view, SGLT2 inhibitor might be better for this patient. Dr. Yogesh asks if we can use injection degludec aspart twice a day. Yes, we can, sir. Once a day, twice a day, both are comfortable. If RBS random glucose is 350, let the glucose come down and wait for around 2 weeks. You tell the patient for eye surgery that you in the eye you have a lens. Lens is like it is a sultana or a kishmish or a raisin, and there is a lot of whenever you have high glucose levels, the shape of the lens changes. So let us continue glucose at the same level for around 2 weeks. Let the lens stabilize and then you do the surgery, the outcomes will be better. So minimum 2 weeks we should wait. We have more questions coming up, and Dr. Gangadhar Rath asks, how do I explain high serum creatinine but no albuminuria? This is known as non-albuminuric DKD, non-albuminuric diabetic kidney disease. This is being recognized more and more often, sir. There is a damage to the tubules but not to the glomeruli. That is how we explain it. Dr. Patel from Aurangabad in Maharashtra says, can I prescribe Enerzal Zero in pre-diabetes? Yes, sir. I use it frequently in neuropathy also, and in patients in summer when they come in with the ghabrahat, susti, weakness, also heat exhaustion. Then I use this frequently. It helps our patients a lot. The maximum use I have in my OPD for this product is as a triage. So patient comes in with ghabrahat. It can be acute MI. It can be unstable angina. It can just be heat exhaustion or acute panic attack. So we ask the patient to take Enerzal Zero, sit down for 15 minutes. Sometimes I add a sublingual tablet of promethazine, and we say we'll check again after 15 minutes. If the patient is actually in trouble, cardiovascular trouble like unstable angina or acute MI or TIA, patient will not improve. So we investigate, we refer, we treat. However, if the patient improves, usually we send the patient back on this prescription and we ask them to maintain fluid and electrolyte balance. Dr. Vikas Sahu from Dhamtari, Chhattisgarh has a difficult question. How do gliflozins, SGLT2 inhibitors, affect cardiac function besides diuresis? Sir, what they do is they act upon the mitochondria of the cardiomyocytes. They improve the efficacy, the efficiency of the mitochondria in managing energy balance. And this is known as the Robin Hood effect. If you allow, we can discuss this in a later episode of KK Med Talks or Diabetes Essentials. Dr. Prakash Khute from Rajnandgaon asks if gliflozins have an effect on insulin metabolism. They are insulin independent, but when they bring down the glucose, insulin toxicity goes down. So that is how they help. Dr. Tarun Kumar Pandey from Durg says, barring abnormal renal functions, yes, it is proved beyond doubt that glufosins do not have any extra effect in controlling diabetes. Okay, so glufosins will not bring too much extra to glucose control, but they bring a lot of benefit in terms of vasculometabolic and viscerometabolic control. So of course you need to get good glucose numbers, but along with that you need health of the heart, the kidney, the liver, obstructive sleep apnea. In all these, gliflozins have got benefits. So that is why we are using them for glucometabolic plus vasculometabolic plus viscerometabolic benefit. So we must give. Question is there a group of people who respond well to double the dose of gliflozins? Not tried, no. A single dose would be there, or at the most two doses, like empagliflozin 10 and 25 milligram. So no point in going to 50. It will not help. And there may be a genetic explanation for this. Yes, certainly. May be a genetic explanation for this, but we will not go beyond the recommended doses. Do gliflozins have an effect on insulin metabolism that we discussed? They reduce glucotoxicity, but directly they don't cause insulin release. Dr. Gangadhar had a question: which calculator is used for EGFR? So EGFR, you put CKD EPI equation. Just put EGFR calculator and it will come automatically on your phone. For ASCVD risk, I prefer Q risk 3. Capital Q, capital R, risk, Q risk 3. This comes from UK, but it is based on a multi-ethnic population. So you can go in and put Indian ethnicity actually, and that will help. And same Dr. Jenna, HbA1c 8.9, insulin 30 units a day, and metformin glimepiride. Ideally, we should not be giving glimepiride and premix together. We can give glimepiride and basal. For this patient, we have not seen the patient. First of all, we should rule out infections, UTI, GTI, tuberculosis, diabetic foot. Then you rule out irritation. Is the patient sleeping well? Is the patient happy at home? Then you rule out invasion, any kind of a tumor or something, anything that is required. Rule out iatrogenic. Patient might be taking alternative therapy. Patient thinks he is taking Ayurvedic treatment, but actually patient is taking steroid powder. So rule out infection, inflammation, irritation, invasion, iatrogenic. And then if things are not working for this patient, we might wish to stop glimepiride, add SGLT2, increase metformin, increase dose of insulin. But if after giving 20, 24 units, sugars don't come down, we ask the patient to go to basal bolus or 3 dose for a few weeks. And that will actually bring down the glucose. With this, I'd like to thank everybody who has logged in today. One last question we'll take from Dr. Kuldeep Singh. At what time will you introduce Finranon? So as soon as the EGFR goes below 90 with albuminuria, and if it goes below 60 without albuminuria also, we will start Finranon. Albuminuria, you can check by microalbuminuria or UACR, urine albumin creatinine ratio. Both are fine to check. So the moment you diagnose CKD, albuminuria plus EGFR less than 90, or you diagnose EGFR less than 60, even with or without albuminuria, we should start Finranon 10 milligram. Just do a sodium potassium before starting. Potassium should be less than 5. With this, I'd like to thank everybody who has logged in today. We had a long discussion. I apologize for the late start, but we'd like to thank Hitesh once again, Dr. Hitesh, for having been with us and for having shared his expertise. And from the comments and questions, I realize that it's time to get him again on stage and more frequently. And perhaps we need a change of host for Diabetes Essentials. What do you think, Mr. Basu?
No, no, sir. We can't imagine. I mean, let me put it very straight and forward. The whole journey is with you, and we will like to go with you only, sir. However, the way you have interacted with the guest speakers is amazing, and I think the reason behind so many question and engagement, engagement going 1 hour 15 minutes is because of the start you had, sir. I think, and most of you will agree with us that the way you have started with a very most commonly CME kind of topic which we already have in the diabetes sessions. But the way you have started, I think that it continued the engagement, and then the speaker came, and then the knowledge, and then the continued engagement, sir. So, with not taking much of time, sir, but so much thankful to you because you've been so patient that each and every question, even the questions which because last week we couldn't post, that has also been covered today. And I tell you, sir, the doctors who have received last week's question and answer, they really thank you because all the questions were answered. And today also, when the name of the doctor and along with the city of the doctor is being given, then we cut the clip and we send it to them tomorrow and maybe day after tomorrow. That's it. By Monday and Tuesday, they will have the clip. So that's the amazing services you are doing, sir. Last time also I spoke about it. Doctor sitting in Dhamtari or doctor sitting in Saitia and West Bengal, they get that clip in hand and get their name and a city name and then the question and answer. That increases the evokes the enthusiasm and the engagement that we are having. That's why, sir, I continue to say that diabetes essential is with you and it will continue with you, sir. We can always choose the doctors and the speakers as you wish, and we are also remind let all viewers be reminded today that we are yet to have three international speakers in this year, and we are actually working with Dr. Sanjay Kalra on different aspects to get the in thing from the Western worlds. First in hand information from the Western world, clinical evidences with Dr. Sanjay Kalra on this. With this, we thank Dr. Sanjay Kalra and all the viewers being with us. Good night and Jai Hind.
Jai Hind.